Good morning. Good morning, everybody. Without further delay, I will go into introduction of my lecture, Dyslipidemia and its residual risk. Okay, we would like to know about the burden of cardiovascular disease before we talk about dyslipidemia. Okay, it is the #1 cause of death worldwide and attribute to most of the mortality worldwide, accounting for 17.9 million per year. What about the Gulf countries? 45% of all mortalities in Gulf countries are attributed to cardiovascular disease. Middle Eastern, when they get cardiovascular event, their lifespan is reduced by 12 years. Most of the time, they are having dyslipidemia and obesity. So 40% of all cardiovascular causes of death in UAE is attributed to cardiovascular disease. Similarly, in Kuwait, one out of 5 who had MI, they will develop another cardiovascular event within a year. So how to prevent that? Okay, what is the major risk factors? We should look into them. So, dyslipidemia. Which dyslipidemia? I'm talking about atherogenic dyslipidemia. Raised triglyceride, a small density lipoprotein, and low HDL, and mainly seen in our area, metabolic syndrome, obesity, and diabetes. So, when we look in many meta-analyses, we're only focused on statin therapy, on those patients who are having atherogenic dyslipidemia, still there was many event was not met or was not prevented, as you see there in the graph. So, lowering LDL to target, still there was 78% of the risk of major cardiovascular event which has been unaddressed. So that means we should do or think about something else. It's not only the LDL target. There is something else missing which we have to tackle. So here, by lowering the LDL cholesterol, even further, by maximum dose of atorvastatin, still we reach just 2.2 absolute risk reduction. So it's time to talk about non-HDL, and when we go through many guidelines, they address after controlling the LDL target, talking about non-HDL. So in this study, okay, many meta-analyses, they show that, just look here down, when LDL is in target, but the non-HDL not in target, still the hazard ratio is more than 1. So that means you should look into that parameters when you attain LDL targets. In many studies, or if you want to achieve LDL, non-HDL, if triglyceride is high, more than 2.5 millimole, you will not attain LDL or non-HDL target. So you have to think of triglyceride or hypertriglyceridemia. What is non-HDL? It is simple. It is total cholesterol minus HDL cholesterol, okay? And it represents all the atherogenic type of dyslipidemia, like low density, intermediate, ApoB, and so on. So, what's the advantage of non-HDL measurement? Does not require fasting, easily calculated, 2 standardized assay, total cholesterol minus HDL cholesterol, and can be used even when triglyceride more than 400 milligram per deciliter, accurately. What about LDL? There is a lot of pitfall of measuring LDL alone, okay, because it's invalid when triglyceride is more than 400, and inaccurate when triglyceride more than 200 milligram per deciliter. If you are interested to convert it to millimole, divide it by 88.8 or 89. You will get the millimole level. Okay, what about the guidelines? Guidelines on dyslipidemia. National Lipid Association, European Society of Cardiology, American Association of Clinical Endocrinology, and so on. What's the guideline? What tell us? Yes, definitely. All the very high-risk groups, they look into LDL target, however, they added non-HDL. So when we reach, we don't say that statin is not the first line. Statin is the first line in tackling dyslipidemia and preventing cardiovascular event. However, you should look into the non-HDL target where you have to add on for statin. So very high, you have to have an LDL less than 1.4 millimole, which is 55 milligram, and non-HDL below 80 milligram per deciliter. We are not far away, even in our Middle East consensus. They added LDL and not HDL target, according to Nasreen assay data. So, how you tackle LDL reduction? You know the statins, moderate intensity statin will lower your LDL by 30%, high intensity more than 50%, and add on getting ezetimibe 65. If you don't attain target, you have to go and add PCSK9. Just pathophysiology of atheroma, okay? Smooth muscle damage, lipids is there, laden, then rupture, then the patient will have a cardiovascular event. How to prevent it? LDL, non-HDL. So what we know about non-HDL, it has been shown that it has a strong predictive value to cardiovascular event. Non-HDL is simple to calculate. Both Residual formula and LDL cholesterol estimation have limitation, especially when there is high triglyceride. Non-HDL should be used as a secondary target when LDL goal has been attained or achieved. So, non-HDL cholesterol in the guideline, triglyceride analysis is recommended as part of routine lipid. Non-HDL calculation is recommended in all metabolic disorders, metabolic syndrome, patients with diabetes and obesity. So, what are the summary of dyslipidemia and metabolic syndrome? Dyslipidemia represents a cluster of lipids, lipoprotein abnormalities, and when we talk about all those types, we are talking about the atherogenic dyslipidemia, as I state, raised triglyceride, small density lipoprotein is high, and low HDL. Non-HDL cholesterol guideline, according to AACE, American Association of Clinical Endocrinology, still you have to achieve your LDL goal, but still when it is unachieved or you did not prevent the atherosclerotic cardiovascular event, you have to look on the other parameters like non-HDL and triglyceride. And it is a simple method to measure the non-HDL, just total cholesterol minus HDL. What about the guideline in ACC? Still, they recommend lowering non-HDL in addition to LDL. Now, out of all these 9 modifiable risk factors, the most impact is to lower the lipids. You can achieve many things by lowering lipids, even if you fail controlling his diabetes mellitus, number 3, I think, or 2. Just by controlling his cholesterol can prevent many cardiovascular events in patients. What about triglyceride as an independent risk factor for cardiovascular events? So, which screening should be chosen? You should choose to check triglyceride in comparison to non-HDL or apolipoprotein. Why? Because the level of triglyceride, when it is more than 150, it will give you a clue about insulin resistance. When it is more than 200, it indicates a substantial increased prevalence of atherosclerotic cardiovascular disease. And this is a grade of level of triglycerides. Now, triglyceride-rich lipoprotein cholesterol versus small dense lipoprotein cholesterol when you attain targets or when you control them. They found that controlling triglyceride can benefit you in preventing MI and peripheral arteriovascular disease. However, just small density lipoprotein is just for MI and not for peripheral vascular disease. Triglyceride, when it is more than 2.5 or 200 milligram, it has an independent risk factor of all cardiovascular event and familial cardiovascular disease. How to treat triglyceride? What's the role of fenfibrate in treating hypertriglyceridemia? So in many studies, like in patients with diabetes after attaining LDL, adding fenfibrate, especially when triglyceride more than 2.3 millimole, which is more than around 200 milligram per deciliter, you can get relatively 27 or 31 relative risk reduction with a number needed to treat of 23 and 20 respectively. Still further, a statin combination with fenfibrate reduced the risk of major cardiovascular event, especially in groups who are having raised triglycerides. So I am just so very specific. You tackle those patients who are having combination of the atherogenic dyslipidemia, small density lipoprotein and raised triglyceride and low HDL. Those patients who will benefit most from combination of statin and fenfibrate. So a combination of fenfibrate with atorvastatin reduce all the parameters of dyslipidemia and increase HDL, as you see here. Now, what this study tells us, use of fenfibrate on cardiovascular outcome in statin users with metabolic syndrome propensity match cohort study. So, as we know, randomized clinical trials on fenfibrate alone treatment have failed to show reduction in major cardiovascular diseases with diabetes. However, there was statistically significant cardiovascular risk reduction in the subgroup who are having atherogenic dyslipidemia. I am attributing to raised triglyceride with high LDL. With high LDL, yes. So what this study tells us? The risk of major cardiovascular event was reduced in adults with metabolic syndrome using fenfibrate as an add-on statin. Especially you can see here in the middle, the group who are having raised triglyceride, there was significant reduction of all cardiovascular events when combination has been attained. So I don't advise to combine statin and fenfibrate when triglyceride is on target or non-HDL in target, but if the non-HDL or triglyceride is high, those patients please concentrate on adding fenfibrate. So in this propensity weight cohort study of adult and metabolic syndrome, the risk of major cardiovascular event was significantly lower with fenfibrate add-on statin. Now, when we talk about combination, definitely most of the primary care physician here in our local area, they will fear myopathy, especially when they look into our electronic system, iSaha. It will just raise that myopathy or the combination will cause for you a side effect. Please look into that. I just assure you, adding fenfibrate to statin has 15 times less reduction of presence of myopathy on those patients in comparison to gemfibrozil. What about the guidelines? It's there in the guideline. The safety of fenfibrate on combination with statin, they state that according to European Society of Cardiology and European Atherosclerosis Society guidelines, they said combination of statin with gemfibrozil enhances myopathy. However, you don't have it or to a negligible part when you add any type of fibrate, benfibrate or bisfibrate. So what about the guidelines? Yes, as stated here, whenever you attain LDL goal and triglyceride more than 2.3, please add fenfibrate or bezafibrate. What about AACE? Still again, whenever there is LDL controlled but triglyceride is high, think of omega-3 and think of fibrate. Now we'll go into omega-3. So, prescribing omega-3 for the treatment of raised triglycerides. What's benefit, what it will add on, and how can we achieve in combination with statin. So, a favorable effect of combination of lipid profile, all the atherogenic type is reduced, HDL also some is raised, sometimes to a small extent LDL raised, but in very small meta-analysis. So, in patients with diabetes, benefited from combination of triglyceride and non-HDL. So, adding omega-3 to atorvastatin, there was significant reduction of triglyceride and non-HDL. Even with adding with rosuvastatin, there was significant reduction of all the atherogenic type, triglyceride, non-HDL, and LDL. So, Patients with diabetes or without diabetes who are having raised triglyceride, they significantly benefited from lowering triglyceride by adding omega-3 of up to 4 grams per day, and it was very safe. Non-HDL is the most inclusive measure of all atherogenic ApoB, and it is reduced significantly in diabetic patients when adding Omacor. What about pancreatitis? To reduce the risk of pancreatitis, a fibrate prescription in combination with omega-3, aiming to reduce the triglyceride less than 500 milligrams per deciliter. It is a standard of care to prevent acute pancreatitis because raised triglyceride is a risk factor for the development of pancreatitis. Now, is all omega-3 can be prescribed? No, it's only the FDA approved. It's only the one who had higher concentration of EPA and DHA and of ester type, sustainable release, covering 24 hours and highly purified. So what we know about omega-3 from advisory boards, a 20 to 30% reduction of triglyceride when you use 4 grams per day, more than 30% reduction in triglyceride with 4 grams, and it is safe even with combination with statin. What about American Heart Association Advisory Board? Concerns have been raised about raising LDL. However, they studied more than 9 meta-analyses, and they found that only in one study there is mild, non-significant increment in LDL. However, it can be covered by statin. And this is the mechanism of fatty acid, Omacor. It's not known, but still can control the triglyceride. I think with this I can conclude, and I open my floor for questions.